Good morning, everybody. It's so great to see everybody on this beautiful Minnesota Friday morning. We have plenty of windows so you can enjoy it throughout this morning. It's so great to see so many faces out there, students, alumni, faculty, staff, friends of the University of Minnesota School of Public Health. I want to ask you, are you as excited as I am to partake in the first ever David J. Fine Distinguished Visiting Professor in Healthcare Administration public lecture? So clearly you're not as excited as I am. So in case you don't know, I'm Tim Beebe. I'm the Interim Dean of the School of Public Health, and it's my pleasure and honor to welcome you here this morning. So before we begin our program, I want to take some time to acknowledge that the University of Minnesota exists on land, the ancestral land of the Dakota people. Minnesota comes from the Dakota name, Minnesota Makoche. It stands for where the water reflects the sky. We acknowledge the ongoing debt that is owed to the Dakota people, and we strive to create healthy dialogue, relationships, and practices that address this injustice, as well as others related to the indigenous people of the state. So for more than 78 years, the University of Minnesota School of Public Health has prepared some of the most influential leaders in the world that have gone on to change how public health is practiced globally. Throughout our history, we've been very nimble, changing our programs and research to meet the needs of the day. But what has held steady throughout this is our commitment to ensure that health is a human right. That has been steadfast since its beginning in 1944, just a few years before I was born. So with an alumni community of over 12,000, and Kalia, that number is right, inside joke. A faculty team of nearly 130 and over 1,000 enrolled students, we continue to see our incredibly talented School of Public Health community lead the public health field. So one of the benefits of being dean, even if it's interim, is being able to look at the entire school and be reminded of its many, many strengths. And we have a very, very strong school. One of particular points of pride is our Master of Healthcare Administration. It is something I've called our lodestone or our gem, and it's something to be very proud of, and we all are. So for 75 years, our program has prepared some of the most outstanding leaders and champions in the healthcare industry. Some of them are right here in this room today. So don't look behind you. They could be right behind you. So as Interim Dean for the School of Public Health, I'd like to sincerely thank Dr. David Fine and his wife, Susan, for their generosity. Without their support, this wonderful program could not have taken place. And I'd like to thank our Dr. Huckman for being our first participant in this wonderful program. I appreciate not only his lecture today, but all the engagement that he's done for the last 3 days. By all accounts, it's gone wonderfully. Some have told me that he's funnier than I am, and that can't stand, so I'm asking him to go home later on today. Last but not least, I'd like to thank the incredible team that's put all this whole program together. They have done an incredible job, including this particular event. So I'd like to just take a moment to give them a round of applause. So now I'd like to welcome former MHA Program Director and current Division Head of Health Policy and Management, Dr. Jean Abraham, to the table.
Good morning, everyone, and welcome. This is an exciting day. I want to begin by first thanking all of you for coming out to attend this wonderful inaugural event. And I also want to personally add my gratitude to the School of Public Health Advancement Team and MHA leadership team for all the work they've put in planning this event. It's a long time coming, and it's so wonderful to see. As Tim mentioned, the David J. Fine Distinguished Visiting Professor in Healthcare Administration event series is a 3-day series that brings to campus a nationally recognized senior academic professional and thought leader to engage with our students, our faculty, our alumni, and the broader learning community here at the university. Without the generosity of MHA alumnus David J. Fine, MHA class of 1974, and his wife Susan Fine, we would not be able to have this incredible opportunity to share a prominent scholar and healthcare leader like Dr. Huckman with our students, alumni, and university population. For 40 years, David had an incredibly successful career as a healthcare executive and university faculty member, bridging practice, education, and academic leadership roles across the country. It's been my privilege to engage with David over the past few years to learn about his career, his leadership, and the impact that he has had on so many students and young healthcare leaders. Through our conversations, I know that David is passionate about education and about lifelong learning. The generous gift that David and Susan Fine have provided to establish this Visiting Professor series is a testament to that. Though David could not be here with us in person today, we are excited that he is actually joining us by Zoom, things we've learned through all the last few years of what we can do with technology. So hello, David, and again, thank you so much for all that you've done in making this, your vision, this reality today. So now I would like to invite Dr. Katie White, our MHA Program Director, to the microphone to introduce our honored guest this morning. Thank you.
Thank you, Jean. Well, good morning. As Jean shared, my name is Katie White, and I am the MHA Program Director. And what an incredible pleasure it is to be here with all of you this morning. And what a pleasure it has been to have Dr. Huckman with us among our faculty, our staff, and our students over the last few days as our inaugural visiting professor. Let me tell you what we had in store for him. Many meetings with faculty occurred, small group meeting with our PhD student, our center researchers, moderating a panel discussion for MBA students and MHA students with panelists, the likes of Brett Edelson, who is CEO of United Healthcare, Minnesota, North Dakota, South Dakota, with Mark Hansberry, Senior Vice President and Chief Marketing Officer at Health Partners, and with Jen Severson, Director of Strategic Partnerships for Best Buy Health. And it was incredible, is what I understand, and can't wait to see the video of that in packed room. And then last evening, a really wonderful, warm MHA alumni donor appreciation event that we had, a nice dinner here in the Heritage Room. So we have kept him very busy. Not knowing what a model is for a visiting professor, we have filled all the spaces. So we are so delighted and happy that you were willing to go along with all of that. So now I am delighted to welcome and introduce to this audience our first inaugural David J. Fine Professor, Dr. Robert S. Huckman. Dr. Huckman is the Albert J. Weatherhead III Professor of Business Administration at Harvard Business School, the Howard Cox Faculty Chair of the Harvard Business School Healthcare Initiative, and the Unit Head for Technology and Operations Management. He currently teaches one of the core curriculum MBA courses, Technology and Operations Management, and he has taught a number of elective courses, including Transforming Healthcare Delivery and Operations Strategy. Professor Huckman is the faculty chair of Harvard Business School's Executive Education Program that's entitled Managing Healthcare Delivery. So you can see the sweet spot he holds for us in this inaugural professorship. He is also a research associate at the National Bureau of Economic Research and co-chair of the management track of Harvard's doctoral program in health policy. Professor Huckman's research focuses on the linkages between organizational characteristics and operating performance, with an emphasis, of course, on the healthcare industry. He is an associate editor of Management Science and has published articles in journals including American Economic Review, Harvard Business Review, Health Affairs, the Journal of the American Medical Association, Management Science, and the New England Journal of Medicine. Professor Huckman also serves as a trustee of the Brigham and Women's Physicians Organization and Brigham Health, as well as an advisory board member for several private companies that are in the healthcare industry. Professor Huckman received his PhD in business economics from Harvard University and holds a Bachelor of Arts in Public Policy, summa cum laude, from Princeton University, where he was also elected to Phi Beta Kappa. Please join me in giving Dr. Robert S. Huckman a warm Minnesota welcome. Rob.
Thanks, Katie. Well, thank you. It really has been just an absolute pleasure to be back here in the Twin Cities after, I've now realized we're probably on the 22nd or 23rd anniversary or close to it of what was supposed to be my first visit to the University of Minnesota. I was on the market as an assistant professor, had a great set of discussions with Sandy Potoff, whom I guess many of you would know quite well. You'll see I didn't get to know Sandy quite as well as I would have liked as a colleague, because the minute I was getting on the plane to come give my very first job talk, I was going to go here, go to Michigan, and one other place in the Midwest, and I'm trying to remember where it was. But my itinerary got shortened unexpectedly. Sandy called me up. She said, "Rob, I hate to do this, but before you even come and give your talk, I'm going to have to tell you your talk's canceled, and we're not going to be able to do it. Not only that, the search is canceled." And I said, "Oh, that's too bad." I said, "What's going on?" She said, "Well, our governor has frozen all public hiring." And I thought to myself, well, gee, that's really unfortunate. It's very drastic. I was like, "Who's this governor you're talking about? And might I lodge a formal complaint with him?" And she said, "Sure, it's Governor Jesse Ventura. You may know him by his former occupation too, and please feel free to go right ahead and lodge any complaint you'd like with him." Needless to say, I kept it right there. I have since been able to come back and give several talks here at the Carlson School, here at the School of Public Health, and just in general have had a chance to reconnect in the last couple days with some old friends in terms of faculty, and meet a lot of new friends in terms of your students here. And it has just been an absolute joy. So I'm grateful to all of you, and I am grateful to David and Susan Fine for making this possible. So thank you. I am going to speak a bit today about a topic that I think has been hanging with me for much of my career. And I hope it doesn't show you how little progress I've made on it, but I hope it will at least compel those in the room who are going to be that next generation of leader to realize there's a lot to be done. And I think it's very important type of work that we need to think about as a healthcare system. So I've entitled this talk, "Putting Healthcare Back Together." There's probably a little bit of a reference to the old Humpty Dumpty story, and I think that's somewhat fitting for what's going on in healthcare delivery at the moment. And you'll see when I talk about the roles of these quote unquote new players what I mean. My career in healthcare delivery ended in the first semester of my sophomore year in college, when I took organic chemistry from a professor named Maitland Jones, who has since become quite well known for causing many budding doctors to reconsider their occupation. I thought he was a wonderful professor, actually. He just made it very clear to me that economics was the thing that I should focus on. He has no idea he did that, but organic chemistry did do that to me. So I've kind of become more interested in how I impact healthcare in a different way. My father was a physician, a neuroradiologist at Rush Medical Center in Chicago for 42 years. My mother was the associate vice president for equal opportunity at Rush Medical Center for 38 years. So it's in the blood, but how I was going to approach the industry was never quite clear. And if my mom and dad were alive today, they would look and they'd say, well, you know, we're still not quite sure, but give it a go. So that's what I'm going to do. And I'm going to walk back a little bit to how we might have thought about medicine. For those of us who remember Marcus Welby, and I'm guessing it's a smaller and smaller group in our audience, but I think even for those who didn't get to see the television show, you'll understand what healthcare was like in the era of Marcus Welby. And for those who don't know Marcus Welby, I figured I'd do this as a how it started, how it's going kind of thing that you see on the internet today. And you know, how this all started was we had this primary care physician who was this all-knowing and all-involved member of our healthcare experience, right? They would help us figure out what was going on. If we couldn't come to them, they would come to our house, right? And then once we had to get into the system and decisions had to be made, they'd be there with us every step of the way, helping to make these decisions. And David Dranoff, who's a wonderful scholar at Kellogg, I think described this very well in his 2000 book. So the how it's going piece of it is that the world's a lot more complicated than the world of Marcus Welby today. And I'm saying today when I'm over on the right side here, you know, citing the Institute of Medicine Crossing the Quality Chasm report, which, as many of you know, I mean, this is over 20 years old itself, but I think the challenges of healthcare remain the same. What's interesting about this, though, is that healthcare is filled with incredible, as I would say, components. Now, that's incredible people, incredible organizations, incredible technologies. You know, assuming you have access to the system, it can be a great ride. If, you know, not that healthcare is something we all want to consume, but you can feel like, boy, I got access to the best possible. The reality is that the system performs quite poorly overall, and it's expensive, and it just doesn't generate the results that I think many of us would like to see. And I keep telling myself, one of these days, I'm gonna not be able to say that anymore. I'm not quite sure this is that day. Because if you look at these things that are really challenging our healthcare system, it's not that, you know, there aren't the great technologies or the great people or the great institutions. It's that, well, it doesn't tend to be timely, efficient, effective. Increasingly, it's not equitable, and that's something we've really drawn a focus to. It's not patient-centered. In many cases, it's not safe. And so these are some basics. What's driving this? Well, I think the first part is just a basic challenge of access. We all know in this room that the ACA didn't completely fix our access problem. That wasn't even its goal. Its goal was to really try to reduce it. And we did see some reduction in terms of those who are uninsured. We didn't see much movement in terms of those who were underinsured. That is, those for whom financial factors played a role in limiting their access to care. Okay, so access is one piece of this. The second piece is the fact that we still have a cost and productivity problem. These are relatively small graphics when put side by side, but I almost don't even have to label anything on the left side because everybody knows what that chart is. It's like, you know, USA, you know, we're number one. And we are leading the charge in healthcare spending as a percentage of GDP. And it doesn't really seem to be closing. Now, there is a whole discussion, much of which has involved some of my doctoral advisors, as to what is that right number, you know, and I do not want to get into that discussion today, because that could be for an entire, perhaps an entire course by a visiting professor, although I have a feeling that those here already are unbelievably well equipped to discuss that issue. I think we'll all say it's a really hard problem to crack. The one thing, the one wrinkle in all of this is that said advisor before, who I mentioned, David Cutler, he and I worked on a paper which had a graphic on the right side there with several other colleagues. And one of the challenges is not so much just the spend, but the relative lack of productivity that we get for that spending. And again, I think for many, I don't have to, I'm not really informing you on an issue here. We do have a bit of a problem in healthcare, which is like, when you look at this as our real industry growth in healthcare, it's, it's pretty significant. When you look at where that's coming from, it's largely coming from more employment in the industry, not greater labor productivity in that setting. And I don't think it would come to a surprise to many to think about all the places where healthcare makes the ability of those amazing people to do their job at the level they would like quite challenging. Okay, and so we have kind of that issue. The final piece is, again, on the outcomes that we often don't look at enough in this country, we still do pretty poorly relative to other countries. These data are somewhat dated, but not all that inaccurate. When you look at factors like life expectancy at birth, infant mortality rates, the level of chronic disease in this country, the U.S. is just not, doing what its spending would suggest it should be doing when it comes to outcomes. So the upshot is, again, another chart where maybe I didn't have to put the axes labels on here, but this is a chart that was actually put together in the Kaiser Family Foundation, where essentially we're spending very high, and we're not getting very much in terms of system performance here. So hopefully to this group, as discouraging as this is, I'm hoping it's not all that surprising to see this. So now the question is, well, what else have we done possibly that makes this challenge even greater for us? And some of these wounds are self-inflicted, not just by, shall I say, policy, or by the fact that our consumers are in a position where maybe they're not able to be the most informed. But the reality is, there are many things we do with the best of intentions in healthcare, and they add fuel to the fire. So on the left is and I'm sorry for the way the axes or the way the different columns are spread out here. There's a little bit of what I would say a Wall Street Journal graphic problem here, where it's not exactly equally spaced, but I think the idea is there. And if you look at the American Board of Medical Specialties, the number of subspecialties that we have in medicine has really grown dramatically. Now, on the one hand, you can look and say that is wonderful, right? It used to be that I could see a cardiologist or I could see an endocrinologist, and now I can see a cardiovascular endocrinologist if I suffer from diabetes and heart disease, which, by the way, if you look over on the right side, is pretty common. Okay, so that right side graphic actually is from a paper that I worked on with Jonathan Clark, who's now at UT San Antonio, and was a doctoral student that I advised several years back. And in this work, we were looking at the degree to which hospitals that were highly specialized in cardiovascular care actually got better cardiovascular outcomes. And our result was sort of interesting to us, because on the one hand, at a first order, we said, well, sure, it does look like hospitals that focus on cardiovascular care do pretty well for patients who are having coronary artery bypass graft surgery, open heart surgery, which was one of the most common things that was done in the cardiovascular sphere at the time. However, what we noticed was it's not just the degree to which that hospital's focused in cardiovascular care that matters, but actually the extent to which they're focused in things like endocrinology and respiratory and in the digestive system and kidney and urinary tract disease, right? And these all happen to be things that patients who have a cardiovascular diagnosis also happen to have. So this idea that there was such a thing as, well, I'm a cardiovascular patient, it's much more complicated than that, and perhaps not surprising given the range of comorbidities that can happen. So we get into a world where people deal with specific slices, but the patient comes to us with a wide range of needs. And so it's very important for us to think about, how do we serve that need? How do we put their health care back together? So around the time of the Affordable Care Act in this country, my best summary of what we expected consumers to do is probably this picture, which I did not draw. but suggesting there's a certain superhero element to our consumers. And if we just unleash them, the power of consumerism would take over, and it would right all of the fragmentation, all of the inefficiency, all these other things that we could do. Now, I understand nobody actually said that to that extreme, but there was a smidge of implied, like, we can expect consumers to do a lot more and really put a lot of this load on them. And so it's not surprising that when we talked about consumerism, and this is data from sort of either side of 2010 here, we sort of said, well, we're going to put more onto the consumer. And in this Kaiser survey, we sure did put more onto the consumer. We actually increased the proportion of the contribution to premiums that was borne by workers. So you see that increase of 81% there in the worker contribution, as opposed to a 69% overall increase in premiums, which means employers were taking a much lower portion than the consumers were. So part of consumerism 1.0 was just more cost sharing for those consumers. Now, that's not in and of itself a bad thing, for sure. But here's a bit of the rub. We also said, well, look, how are consumers going to make the right decisions? And I think at the same time, we were coming off of a world where so much information and data was being reported in the form of public report cards, right? I don't know if anyone in this audience is or was recently a practicing, say, surgeon, but if you were, and if you were in something like bypass surgery, orthopedics, we can name a whole host of other places. Angioplasty is a interventional cardiologist, let's say. Chances are there's a state-level report card about the mortality results for the patients that you served. It certainly would kind of identify what those rates were like at hospitals, and for high-volume providers, it would identify what your rates were as an individual practitioner. Okay, those report cards were out there. In addition to that, we put out these report cards about different payers and their plans, about hospitals, doctors more generally, and we put all this information out there, and essentially patients didn't use it. I mean, you saw in 2006, we sort of tapped out a bit with about 1/5 of patients saying they ever used data about a health plan, a hospital, or a doctor in making their decisions. This is publicly provided data. So we have this situation where we've got people on the hook paying for more of their care. We don't necessarily give them information that they're using. We try, okay? But we've got patients who might be somewhat uninformed, but really bearing a fair amount of the risk. Now, this is where I have a chance to cite a piece of work from someone who I had the pleasure of advising when he was a doctoral student. That's Jonathan Kolstad, who's at Berkeley now, as well as several other colleagues from Berkeley and from Harvard. My colleague Amitabh Chandra at Harvard is also on this paper. This is a paper that I understand many of the students here, doctoral students, have actually maybe had on a qualifying exam or something like that. So maybe I should turn things over to the floor and have you explain this, because yesterday you all proved, at least your MHA students, that you guys are ready to teach the class. So I am, but what was interesting about this paper, this was actually a study of, and I need to try to at least formally preserve some degree of company confidentiality and say this was a large technology company, where, as you can see, the employees had median income in this $125,000 to $150,000 range, so it was a pretty well-performing, because it was large and well-performing. So we're getting into a smaller and smaller set of companies, but you can ask others. But I will say that the main result of this paper was that when they put these employees, these very well-educated, thoughtful employees, onto a high-deductible health plan where they had to bear that first dollar coverage to a significant degree. And what they found, the first thing were those two big bars there in the sort of the third set over, which is the quantity of services consumed in total. right? And sure enough, after this, it dropped. Okay, well, so we put people on the hook. They had to take care of spending, and lo and behold, they responded to that first dollar incentive and they stopped spending. Well, unfortunately, they stopped spending on some pretty important things, some relatively high value primary care services. And so that was one concern, that even these highly educated folks were just saying, I'm gonna take that incentive you've given me and I'm gonna do what you want me to do, and I'm gonna cut back my spending. What's interesting though is they didn't exactly just cut back indiscriminately. In fact, I was struck by this other result over here, which is a smaller one, and if you can't see what that says, it says shift to more expensive providers. So wait a minute, we're cutting back on our spending, but at the same time when we do this, we start consuming from more expensive providers. Okay, so the indication is we didn't give these individuals enough information about the relative quality of these providers. We gave them information about the relative cost, but we didn't give them the full set of information. And so what did they do? They did what I would do when I buy wine, right? I look at the event that I'm going to. If I'm meeting my in-laws for the first time, I'll probably buy a $40 bottle of wine or something like that, maybe 50, I don't know. I'm going back to when I met my in-laws 20 years ago or 25 years ago, okay? I don't know wine that well, so that's what I would do. I might, get one with an interesting label, but I'm definitely gonna get one that's at a certain price point, right? Why? Because I'm assuming it's pretty good quality. How could they possibly keep that price going if it weren't, right? And so we might actually consume other experience goods, which healthcare is one in that similar way, and this result sort of showed it. But this gets me a bit more concerned about putting power in that all-powerful consumer unless we really, truly equip them the way they need to be. So what is my view of what a different form of consumerism might look like? And I use the term distributed care to refer to this, and clearly from the discussions of the last day and a half, this is on everyone's mind now, that they'll talk about it as hospital at home, moving care from bedside to home, thinking about anything we can do on those little phones that we have in our pocket, managing our chronic disease on any number of apps, whatever it may be. We're seeing this move of care, not surprisingly, from hospitals and ambulatory centers in this common location that we used to travel to, probably because Marcus Welby told us to travel there, right? And now we're moving into a world where we still have that. Those are our existing providers, but we've got all these new options, and I'll say new as in in the last 20 years, for retail locations, and probably increasing in the last decade more so for healthcare in the home. And there I put a bunch of organizations, and I just put up some examples just to give you a sense of what I'm talking about when I refer to entrants, okay? I'm not talking about small startups in Silicon Valley that are probably gonna be quite amazing in some cases and are gonna have a lot of failures in other cases. But I'm really talking about larger organizations that have maybe been on the side of healthcare for a while and are moving more squarely into healthcare delivery itself. Okay, so think of the CVS Health, Walmart's, Best Buy, as we heard yesterday, wants to be a major player in this space, although in a particular way. And really the goal is let's increase convenience, let's increase self-service, let's increase access, maybe even increase the scope of practice that we bring to bear, and hopefully reduce unit cost and keep people kind of satisfied, served, and able to actually consume healthcare. And I put consume in there because that means being a consumer, right? And when we order something on Amazon Prime, we are consuming, and we all often marvel at how quickly they can get us, dog food or, paper towels or whatever. And we wonder, gee, what else could they do? And what else could they serve in that kind of efficient way? So we'll hold that thought for a minute. So I want to talk a bit about this group over on the right. I'm going to call them diversifiers because they're a kind of entrant who's diversifying from something else into healthcare delivery, in my view. I've written a bit on what the potential might be here. And for those who are doctoral students, either current or future, or MHA students who are interested in research, I'm hoping that your generation will dig into large sample research on these topics. as I'll say in a minute, it's going to require some pretty interesting and novel data sources, but we're not far away from creating those, and in some cases, they're probably already being created and in progress. But I spent some time when, first looking at this when Amazon announced its Haven venture with JP Morgan and Berkshire Hathaway. That's kind of gone by the wayside now. When that went by the wayside, that was the first time people said, "Oh, Amazon's never going to make it in healthcare," right? And then they went and they, purchased One Medical, and everyone's like, "Why is Amazon doing this?" And then, they're not, and then they closed down Amazon Care. They reduced Amazon Care, and then, Amazon's getting out of healthcare. The news is they're just never going to get out of healthcare, is my guess. I'm just not, I think they may not, like many other large organizations, know exactly how they're going to play in that space. And so they're preserving some options, would be my sense. So in some of these pieces, I've looked at, like, what does it mean to kind of build up a set of skills to help fill in that move toward distributed care that I think could come from some pretty basic service approaches that companies like Amazon, Walmart, Best Buy, and others know quite well. And I recently wrote a case on Walmart Health and how they're thinking about the retail clinic. I don't know, this must be their 5th or 6th version of retail clinics that they're doing now. And they've been at it for the better part of 2 decades. And even that is still changing, like, as we speak, and the approaches are changing as we speak. But I think in many ways, to some extent, these diversifiers could actually create their own health-specific business lines, like Walmart Health, like PillPack, at Amazon, a whole host of other things, Best Buy Health itself, right? But I also think these organizations bring a whole host of more general skill sets that when we talk about healthcare delivery, we tend to focus so much on who knows healthcare, and we ignore who knows delivery. And what does delivery mean, regardless of the service? Well, it means you know something about probably technology, about data analytics, about how to manage a set of locations, right? How to think about distribution and service channels, regardless of what the product might be. And how do you actually manage a massive number of employees, which we go back to why the Haven venture started. It was to try to create a way to manage the healthcare needs of a large set of employees from 3 companies. And they figured if we could figure that one out, maybe there's something we learned that we could then bring or sell to other companies who are also trying to manage a large number of employees. So there's a lot of resources that these diversifiers bring to sort of thinking about how to improve healthcare management. But I will be the first to say they are not healthcare experts necessarily. They are, in my view, delivery experts. But that's important still. That piece still matters. So when we went into COVID, I think it provided a bit of a glimpse of what the potential of a more distributed care model could be. And if you recall, this was what a hospital looked like during COVID. This is one version of a hospital. It happens to be in Central Park in New York. It doesn't exist anymore as far as I know. I'm not even sure how heavily it was used, but I'm told, fairly intensively for a relatively short period of time. But hospitals like this went up all over the world very quickly, and they served a pretty important need that effectively expanded the hospital capacity at a time we needed that done, okay? This was a diagnostic testing center. This is a parking lot of, a large big box retailer. And this is what we did. We did this in our cars. State of Texas set up the Fair Park vaccine site at a major fairgrounds in Texas. And they brought Toyota in to run the Toyota production system to make sure they could figure out how many cars could we sequence at once, because they had to have people drive up and then they had to prep them, put their left or right arm out the window. And it truly became, these mass vaccination sites were not about, well, gee, what's going on biologically when we put this vaccine in? But it was more, how do we process large-scale service transactions in a convenient manner? And then this was a medical appointment. And by the way, for those who follow patterns in telemedicine, I know there's tons in this group who study it. For a while, this was the only medical appointment we pretty much could have during the pandemic. It's come back down now, and it's now stabilized at a significantly higher level than it was at before the pandemic. But perhaps I would say still somewhat underused because of the system in which we've wrapped all of these wonderful and very, in many ways, cost-effective innovations into. And so there's really this question of like, what, we actually proved the technology at that moment. And now the question is, how do we actually build off of that now that we're in a different stage of this pandemic, not quite as acute? I know some call it post-pandemic. I've been very reluctant to do that myself. But nonetheless, I think we are at the point where we could start to think about stable learnings that might have come about because of it. The other thing this pandemic did, and it's also related to this idea of how can we better distribute care, is it underscored something we knew well before that pandemic, was that these social determinant needs are absolutely critical to being able to serve what we have called the healthcare needs of these patients. And what has been so challenging for the medical profession is that every provider to a person almost says these are critical and they need to be addressed. And then many of them say, I don't have the time to discuss them. I don't have the skill set to discuss them. This wasn't what I was trained to do in medical school. And frankly, coming off of our panel yesterday, there was a great question from one of the students in the MHA program that said, where do the bounds of what you do as a healthcare provider, this was to health partners, where do the bounds of what you do as a healthcare provider stop? I mean, you could go into housing, you could go into a whole host of social services, making sure there was broadband access and all of these other things. How do you decide where to stop? And the reality is, like, this tells me this is a systemic issue that we need to solve with someone other than just the healthcare provider. And so that's part of what I think is motivating, where I'm hoping we could see both managerial and academic research go in the future on this. Just to underscore this point, I'm going to reference something that Saye Nikpai and David Cutler and I worked on, so I will reference an amazing member of your faculty here. David and Saye were talking about this right around the time of the pandemic, and we were in a discussion, and we were like, well, maybe there's a viewpoint to be written on this. So we did, and it's interesting. You have to kind of, if you look at the shaded area, you have to give us a little bit of the benefit of the doubt, because we were talking about, well, what's it going to be like in a couple months when we have to be, in the final permanent outcome of all of this, and even we underestimated how long that was going to be. But the general picture was like, what's this system going to look like when all of this very challenging transition has gone through? What will we have learned from it, and what will be different about it? So I want to kind of talk a little bit about what might be different. And I'm going to start by just speaking a bit about some of my own research. One piece from 2006 and one a little bit more recent from 2021. But I've spent a lot of time thinking about who's on the healthcare team and does that matter? And of course, I think our first thought was, sure, it matters. I mean, you'd love to have a qualified clinician on your healthcare team. That would be pretty important. But the question is, who else needs to be on that team? And so my colleague Gary Pisano and I spent some time looking at cardiac surgical teams and said, how important is that surgeon, that person, she or he leads the team, versus all the other members of that team, the nurses, the techs, and others. And so we were able to take advantage of an interesting situation in Pennsylvania where surgeons would move across hospitals literally during the course of the week. So they were the same surgeon, whether they were at hospital A in the city or hospital B out in the suburbs. But their teams were different because the teams were employed by those respective hospitals. And we found certainly that these teams really did matter. Okay, this wasn't just about if you need a bypass surgery, you find the best surgeon and you just go to them whichever hospital they tell you they're going to see at, just go to it. No, you'd like to know, hey, how frequently do you work with the team that you're about to use when you operate on me? And so that element of familiarity, I think, became a big piece of my own work. Later, I've actually started looking at teams in the context of primary care. And I'm using data from Athena Health, which if you don't know the data, just ask Professor Naprash. She knows it quite well, better than I do. But working with two doctoral students in our program, Max Pani and Lucy Chen, we actually asked, well, to what extent do teams of providers versus solo physicians typically, or solo providers, and they're typically solo primary care physicians. To what extent do teams do better than solo providers in managing chronic disease? In this case, things like diabetes and hypertension, what have you. And what we found was, sure enough, these teams actually seem to do better on a lot of these process measures of compliance for chronic disease. This is relatively straightforward healthcare. No healthcare is easy, but this is on the more routine side. And that struck us as quite interesting. What struck us as even more interesting was the fact that teams are better, and it doesn't really matter if that team is composed just of physicians, nurse practitioners, PAs. The idea is you're having qualified clinical professionals who are all bringing their eyes to a problem, and you get a better outcome. And it speaks, in our mind, to sort of how we think about where another opportunity might exist to kind of put healthcare back together, which is to leverage a broader range of providers and increase scope of practice. So the reality is like if we increase scope of practice, that's about managing those teams over on the left, which look very much like your typical kind of clinical team. But the picture I was painting before, where we get into all these things about getting to the home, how do we deal with social determinants of health, how do we get into all of these other pieces, that creates something that adds a bunch of those yellow boxes there: housing, transportation, nutrition consult, internet access, all these other things. You are basically talking about making this problem of integration even more complicated. You're adding more pieces to it and saying more has to happen. And so this is a really big and significant challenge. So I think the answer to this has to be something that brings together really three kind of key groups. Patients, obviously I don't think they need any explanation who they are. They're also our consumers in this case, I would say. Providers, this is hospitals and physician groups, and nurse practitioners, PAs, and others. And then these new entrants I was telling you about, these organizations that are just making their move into healthcare delivery. They're kind of relationships that exist. By the way, I put payers, biopharma, and devices in there too, because if I didn't, you would say, well, doesn't pharma play a role? Don't payers play a role? Absolutely, they do. But I want to try to focus on this point of delivering care to the patient and the parties that I see as being kind of most involved in what we might say that last mile of delivery, okay? So the goal is, how do we strengthen these relationships? And I have like a bit to say about each of the branches of this triangle, right? So if we're gonna strengthen that relationship between patients and providers, we need to move to models that look a little bit more like co-production. We see this in a lot of other service contexts. For anyone who uses a bank ATM, you're co-producing, right? I think there's no question. You're doing a job that used to be done by a teller, right? We've often talked about that in healthcare. It doesn't mean that the patient's gonna go in and start doing their own procedures, for sure. However, one way to think about this is, well, how do we actually get patients and providers to begin to see the world like one another, right? So the providers need to think more like their patients and say, well, what are the preferences of my patient? And how do I provide advice with those preferences in mind? Because sometimes they really do matter in terms of determining what the outcome is. Patients need to think more like their providers, right? Now, this might require some education, deeper education from those providers themselves, but we need to find ways through things like shared decision-making to engage patients in the decisions about their care. It certainly requires both will and skill. Like, we have to be able to do it. That requires some training of these various parties, but the will also has to be there, which is we have to create an incentive for these conversations to happen. And so when we think about how we pay for care, I think it's an important piece to think about, well, where does the compensation come for that kind of consultation? I think many of us agree it's not there as much as it needs to be now, but hopefully with models of payment that might actually not get into paying for specific activities and rather pay for broader outcomes, we might see some movement there. The second part of this triangle is adapting, or what I might call adaptation, as opposed to co-production. When we think about what consumers are looking for from these entrants outside of healthcare, it's a bunch of things like convenience, ease of use, making customers, I guess, not patients, but aware of their options, information about cost and quality. I mean, these are all things that say, the Amazon kind of interface and website does quite well if you're buying books or patio furniture, it turns out, right? But there was once a time when I said, I don't think I'll ever buy patio furniture online, right? And now, of course, I'm like, I'm gonna buy anything I can potentially. In fact, the bulkier and harder to move, the more likely I'm gonna buy it online, right? Let them figure out the logistics of how to get it to my house. And then I just have to be there at probably some time. But I think most important is that these new entrants know a bit about efficient execution of routine transactions. Regardless of what those transactions are, anyone who's been in an Amazon Go store, I'm not quite sure what the future of those stores is, but the technology is being used at sporting arenas and everywhere else, where you just go in and swipe your phone and then you pick what you want off the shelf and you walk out, right? What could be easier to use? I mean, literally, they are making theft legal, it feels like, because you just walk out and you're like, what am I doing? And of course, they do catch up with you, don't worry. But nonetheless, it has made that experience extremely easy. In fact, there was once a time when you could buy a hospital room on Amazon. That no longer exists, but the going rate for a portable hospital room was apparently like $285,000 at the time. I don't know if anyone here has ever invested in one, but imagine that idea of being able to order 6 hospital rooms and set up your own inpatient ward in your backyard. So, these elements are a bit of, obviously of hyperbole, but I think the reality is someone's telling us things need to happen more effectively and more efficiently on some of the really routine stuff that makes healthcare a big hassle. Finally, we have to think about how we reframe. That's this last piece between providers and the entrants, right? When many people hear that Amazon is coming into healthcare on the provider side, it engenders one of 2 reactions. One is that, oh my gosh, the disruptors are at the gate, disruptor this, disruptor that, and we need to, get ready, hunker down and be ready. The other is, healthcare is so complex, they're never gonna, totally figure it out, so we're pretty safe. And the reality is somewhere in between that, right? There are a lot of things, and I think about this, if everything that these new entrants did perfectly overlapped with what providers were doing, well then, yeah, there's a big maybe threat component there, because they're gonna be able to pick off things and be quite efficient. I think the reality is there's some degree of overlap, and there's some degree of unique activities that each brings, which actually creates a real opportunity to think about, well, what does a different model of delivery look like that brings a bit more partnership into this? So if a large healthcare system heard that Amazon was moving into healthcare, they might say, well, gee, maybe there's an opportunity for more of a partnership, something that might feel like a joint venture, maybe even a vendor relationship. When large health IT systems came in, I think many providers said, yeah, it's going to put us out of business, but it's not by competing for your patients. It was going to be by creating so much hassle for you that you're going to want to retire from healthcare. But the reality was that they still were seen as vendors who were working for the healthcare system, right? Or partners who were working together with them, not necessarily as these direct competitors. And so this question of how we reframe what these entrants are doing, I think, is important. It's not going to be the same for all of these organizations, because it depends on who the provider is and what they do, and who the entrant is and what they plan to do. But there could be a lot of opportunities for more of a partnership than this kind of right on top of each other sort of threat. When I think about what this looks like, these are several examples. I'm going to hit on just one of them. One's an example of what Amazon's doing with health lakes and data, which is, as you might expect, they say, show us your data and we'll show you insights. Let's see what happens with all of that. But there's a compelling element that has gotten a lot of hospitals to engage with Amazon, Microsoft, and others as a way to sort of think about building intelligence off of the EMR, the data that's sitting inside of their Epic or Cerner EMRs. I think the example in the upper right, Ochsner beefs up remote patient monitoring with TytoCare deal. That's from a few years back. TytoCare is a device for primary care. It allows an individual at home for $300 to have essentially an otoscope, a stethoscope, several other forms of scopes, blood pressure, other things, all in one device. And you can now have a telemedicine visit with your own doctor if they're telemedicine equipped, and they can say, put, the otoscope, that's the ear, right? Yeah, put the otoscope in the ear, right? Put the stethoscope over your heart. Let's do the blood. And you get many of the things, with the exception of, figuring out, feeling, the glands or palpating a belly. But who knows? One of these days I could imagine I'll put my neck into some device at home, and they'll be on the other side, with a device there, figuring out whether or not I, in fact, have swollen glands. But the reality is that that device was made by a separate technology provider. It was sold in Best Buy stores to consumers who were then using it to connect with their Ochsner physician. And in fact, Ochsner was creating the relationship with Best Buy. So now you see these pieces, all parts of these triangle kind of coming together in, I think, a pretty interesting way that's not particularly threatening to the provider and has a real big role for an entrant like Best Buy or TytoCare, these other device companies, to play. So I'm hoping we'll see more things that look like that. So I know I'm at the end of my time, so I'm just going to summarize a bit when we think about, well, what does it mean to put healthcare back together? And I say this knowing that it is a system that has so many amazing components. I'm going to come back to that point, but it needs help as a system. And when we think about these three things of co-production, adaptation, and reframing, that's certainly a big piece of it. And I mentioned that kind of in the need for relationships to change. But I will say, come back to the piece that the premise of this idea of distributed care that I've talked about is really that if we're going to improve healthcare delivery, we have to not only focus on improving healthcare, but we really have to focus too on improving delivery, whatever that product is. And that's not to be underestimated. For all of us who have frustrations accessing anything about our healthcare that we say, it can't be this hard, it shouldn't be this hard, that's focusing on improving delivery if we can fix those problems. And if the promise of distributed care is to be realized, we need a team that looks a lot broader. It can't be a Marcus Welby, being that all-powerful, parentalistic decision maker for us. And it can't be us wearing capes after the ACA saying, well, just give us the information and let us go at it. It's got to be a different relationship between those two parties and then some, because there are a lot of services that those two parties don't have access to, don't control, and aren't the most effective to deliver. So bringing in these other partners, these other entrants, is going to be important for building new capabilities and perspectives. So with that, I just want to say a note of thanks on several dimensions. First of all, I want to thank all of you for coming here today. It has been an absolute pleasure. As has been referenced already, the beautiful weather, you still showed up, and so thank you for that. I want to thank the Fines, David and Susan, who have had a chance to interact with and get to know over time here, for creating this amazing opportunity for me. I'm quite certain that if my parents, who I had referenced before, my late parents, were here, they would be pretty proud to know that their son made it back to the Midwest. They're from Chicago, so they'd say, well, couldn't you just have maybe stopped over for a day or two and said hi? But I know they would be glad to know that I was here doing this at an organization like the University of Minnesota, which cares so deeply about everything that they cared about when they approached healthcare. And it goes all the way back to Tim's initial comments about the land that this institution is built upon, which I think reflects a huge piece of what needs to happen to put healthcare back together. My final thank you is to the entire team, and I can't even name everyone, but so I won't start. But you know who you are, the leadership of the school, for making this not only possible, but making this absolutely one of the most enjoyable visits I've had in a long time. So thank you very much. I appreciate it.
Great, thank you so very much, Rob. On behalf of the MHA program and the School of Public Health, I really want to thank you for taking time to join us in Minnesota as the inaugural David J. Fine Professor. You've really set a high bar for others who will come to follow. So we have a couple minutes for questions. And so there are some roving microphones, I understand. Do we have some questions that we want to start with? Yes.
That was an amazing presentation and gave a lot of food for thought for most of us here, I'm sure, especially for me. My question is, healthcare has been noted to be fragmented, and that's a common refrain or complaint that people have about it. Mm-hmm. Does this distributed model system that you're talking about make this condition worse, better, or neither?
Yeah, it's a great question. Does this model make things worse in terms of fragmentation or better? I think of it almost like an investment, which is you have to put in something up front with the hope of a return on the over the long term, right? That's how people might think of this as if it were a financial investment. I think it's an investment in a bit of complexity that you probably don't want to be keeping around forever, but you're going to need it in order to expand the set of skills to make this all happen, right? On one of those slides I showed you, a lot of providers say it's extremely important that we figure out social determinant needs, but I was not trained to do that as well as many others who might be much better at serving those social needs. So for some period of time, we're going to have to bring a broader set of people into the team. It's going to get more complicated, and that's where we then have to figure out, well, now how do we simplify this thing that's trying to do a bit more? And I know it all sounds like, gee, isn't this just going to be that subspecialization thing you talked about happening all over again? My hope, though, is that by putting a bigger, not only expanding the pool, but for those key pieces saying, you're actually going to do more yourself, too. You were here already to begin with as a patient, a provider, right, or an entrant, but you're going to do more yourself. And that's a piece that I think a lot of patients, for example, which is one of those groups that's going to have to probably do a fair amount of the lifting, I think they're ready to do it. But they also look and they say, right now I'm unequipped. Can you help me out a bit? And so my hope is that our experience with some of these things, we actually looked at this in the context of patient portal messages during the pandemic using data from Epic. And sure enough, one thing we found was patient portal messages went up during the pandemic, and they have just stayed up, right? It means patients are actually willing to engage with these things they didn't want to engage with before, but we have to kind of create the system in which either that's required, or more importantly, that's not only required, but you're actually able to do it. And we'll see. I mean, now we have to worry about the burnout with the providers that we've created by having so many more patient messages. But that's the next step that we're going to have to figure out, and that might come into how we think about compensation for the time that providers spend answering those messages. And you've seen some movements like that. So I hope we'll figure this out by addressing those things, but it will make things a little bit more complicated in the short term.
Yeah, it sounds like, Rob, on the provider side, we should be expecting a little more mess for a little while, right? A little journey we have.
I would say that I'm not sure that I'm providing too much information when I say yes to that, but yeah.
Next question here.
Thank you for your thoughtful consideration of all these aspects of health and healthcare. I'm curious if you could comment on the power or the deficits that ChatGPT may provide. For instance, you have been talking about the consumer taking the heavy lift. Well, you showed the Superman cape.
Yeah.
I decided to ask ChatGPT what are the 10 questions I should ask my provider about bunion surgery, and within seconds I had it. I wonder if there are strengths and weaknesses that you already foresee using those kind of technologies, particularly around health literacy.
Yeah, and I didn't quite hear all the question, but I heard ChatGPT, so if you hear ChatGPT, you know the question, I think, right? Which is, what is that role going to be? And I will start by saying I am not an expert in large language models, ChatGPT, or other things like that. So I'm, with everyone here, probably an interested observer of what's going on. There are, healthcare has a fair number of chatbot models that have been out there already. One that I thought was interesting, and I honestly haven't tracked it that much lately, was Babylon, which was out of the UK, and it was a very interesting model, and one that I think understood its inaccuracies and where it could and couldn't kind of make determinations. But you would literally engage. You would just tell Alexa or whatever your speaker was, I feel a little dizzy right now, and say, well, what kind of dizziness was this? Is it when you turn your head? Is it, and it would literally show you this update of what it thought your diagnosis might be, and then it would revert to a live practitioner at a certain point. My hope is it reverted to a live practitioner every time, because my guess is that's probably what was needed from a quality perspective. I don't know for sure. But my sense is if ChatGPT has those elements to it and it gets better over time, it could be a very interesting front end for a lot of things. But at the end of the day, as I think about the things as a patient, for myself or my family, the nuance in the decisions here, I think, is always going to be there. And it's going to need that human interaction. So, I do feel like maybe ChatGPT becomes something that serves on the front end as my hope, not something that creates more anxiety, although that is possible, but certainly something that helps channel people to locations where they hopefully will get that human contact, but maybe it's with a better match than we might have elsewise. Yeah.
Go ahead, another question here.
Yeah, I wonder if you can comment a little on inequity in access. We learned from COVID that you have to have a data plan to be able to video with your provider. And so poorer people had to use phone visits. There's obstacles getting to providers in person.
Yeah.
So any comments on how to kind of level the playing field somewhat and make healthcare more accessible to people who struggle to access it?
Yeah, you've hit on, obviously, I mentioned it on a few slides, but it's great to reiterate just how important that challenge is, which is, the greatest healthcare system in the world isn't so great if it can't be accessed, right? And it can't be afforded, all these other pieces. One thing I didn't spend time with in the talk, but I've been thinking about, particularly as you watch the CEOs of large tech companies testify in Congress about their increased power, increased size, everything else is, I am not an expert in regulation, but I would hope that maybe we could think about a way of regulating those who are moving into healthcare in a way that doesn't say you can or can't, but instead says, if you do, here are the expectations of what you will provide and the terms under which some of this will be provided. Now, I have a lot of my colleagues in business schools who will say, well, that's great, Rob, but remember, markets matter and these things. And I do agree markets matter, but rules for how markets operate also matter, right? If you look at an insurance market where we allow payers to have full knowledge about patients' pre-existing conditions and just pick and choose exactly who they want, sure, that's a highly profitable health insurance plan, but we try to have some safeguards to try to reduce that. And so the question is, could we start to do this with other social services like bandwidth, housing, and other things that we feel are important, particularly if a lot of these large for-profits are going to move into that space and try to provide them. As I said, if Amazon can get dog food, which I don't need tomorrow, to my house today, right? Surely if we kind of thought about a regulatory structure, they get a lot of other things to a lot of other people's homes that they needed, in 2 hours or the next day. So
We have a last question here.
So my question is also related to that same topic, which is that it strikes me that one of the biggest barriers for existing health providers, particularly hospitals and clinics, is that they work very hard to maintain the trust of their patients. A lot of the new entrants, what you call the diversifiers, are companies that frankly don't have stellar reputations. And if social media has taught us anything, it's that even if a company has a great reputation today, they might be just one Cambridge Analytica away from a free fall. So how can health systems partner with organizations like Amazon and Facebook while maintaining and protecting the trust that they've built with their consumers?
that is a terrific question, and I had lost the phrase Cambridge Analytica until you had reminded me of it, and oh my gosh, So this trust aspect is a huge deal. And in fact, I want to go back to a little bit of what Jen Syverson talked about yesterday when she was from Best Buy Health, and she was on this student panel yesterday, talked a bit about sort of trust. And the way I think about this now is I think about well, who do you trust to come put a TV on your wall in your house? And some might say, increasingly, I kind of trust Geek Squad. I don't know. I may be speaking, I happen to, but I don't know. I know not everybody does. But some might say, well, there's a certain trust. It's just not for this product that we're talking about here of healthcare. And so I think there's a really great management and leadership challenge for those organizations, which is to say, how do we think about how we could contribute to providing healthcare in a way that gets kind of a similar level of trust that we get for maybe retail service, right? And I realize like Geek Squad's not perfect and things, but when Geek Squad came into our house, people didn't say, oh my God, I'm worried about all of my information being divulged and trust and all these other things being jeopardized. So now we have to think a little bit about, well, in healthcare, how do we create something that looks more like that? But the trust piece will be essential, because one thing that I think would be the greatest database ever created, and it would require the greatest amount of trust ever, would be a database that links someone's purchasing patterns together with their genomic data, together with their electronic medical record and their insurance claims, right? That would be an amazing database. All of us are nod our heads, and I'm sure many people might even be trying to create it. It requires the greatest amount of trust ever. You'll be glad to know that most of the organizations that have all the data about your buying, they're not too willing to supply data to those efforts. So hopefully they continue to use that same degree of protection, but it's a great point.